Thank you very much. I'm going to speak today specifically about Pseudomonas keratitis and an update on that, and just showing you that nowadays with improved OCTs such as the one we've developed in Liverpool, you can actually see more specifically the layers of the cornea that may be infected with these infections, even down to the banded and non-banded portion of Descemet's membrane. So we've been following cases of microbial keratitis for about 13, 14 years, collecting all throughout the United Kingdom. And essentially, amongst the pathogenic bacteria, the stability of organisms causing keratitis is stable. And I think it's a really important point. As you can see here, that Pseudomonas is predominant, followed by Staphylococcus aureus. So we're accustomed to facing a patient with infection. It's critical, as the previous speaker said, that we try and identify and isolate the causative organism, and we should select the appropriate antimicrobial, and then we get outcome. And generally speaking, our outcomes are not terribly good with most cases of bacterial type keratitis, as previously been shown. And the reports you get back in your clinical work tells you that the organism is resistant or sensitive, but what's critical to take on board is that this is dependent on the blood concentration of the antimicrobial, not on the concentration that gets into the eye, okay? So at the bottom here it says to you, for example, that the minimum inhibited concentration is 4 milligrams per liter. That's what needs to kill the organism. That's what you need to get into the blood to kill the organism, not necessarily on the eye. So if you then take different types of microbials, such as these 4 fluoroquinolones, and you measure the sensitivity of Pseudomonas against them, you can see here that ciprofloxacin outperforms its later brothers. And so you need a much lower concentration of ciprofloxacin to inhibit Pseudomonas than you do for Oflox, levofloxacin, moxifloxacin. So still, at the moment, nothing's been shown to be better than ciprofloxacin for Pseudomonas. The next important thing to remember, and I'm not going to show a video here, is that Pseudomonas is predominantly an intracellular organism, so you need an antimicrobial that penetrates the cells. So, for example, gentamicin has poor cell penetration, so you prefer to use a fluoroquinolone which penetrates the cells well. The next point is that when you use antimicrobial, whether it's at the same time or sequentially, you often use combination therapy without necessarily realizing it. So a common thing is you don't want to use, for example, chlorphenical followed by penicillin, because penicillin needs a dividing organism to inhibit it. Likewise, you can use this to your advantage. So if you get a fungal infection, you might want to use, say, rifampicin to make walls in the whole of the fungus, and then use amphotericin, so amphotericin can get into the fungus and kill it. So combination treatment is designed to kill the organism, not necessarily to give you a broad spectrum. So, for example, good combinations for Pseudomonas might be a fluoroquinolone and meropenem, which is usually additive or synergistic, and for Staphylococcus aureus, something like a glycopeptide, whether it be vancomycin or teicoplanin, you combine that with meropenem and fluoroquinolone, that's very effective as well. Whereas you don't want to take something like fusidic acid and a quinolone, they tend to be antagonistic. So having said all that, we can therefore define what we mean by ocular concentrations. This is the concentration needed we feel in the eye to inhibit the organism, and so this needs to be determined for each particular bacterial and antimicrobial combination, such as fluoroquinolone or Pseudomonas, which is usually a lot lower than necessary for the systemic. So having decided on that, you know what your breakpoint concentrations might be. The next thing to consider is, what about the organism's behavior? So showing you over here is a graph whereby on the bottom axis you've got the concentration of the antimicrobial, and going up you've got the clinical outcome. And you can see there's a relationship between the antimicrobial concentration and the clinical outcome, but not all organisms follow that. So you've got a group over here which tend to behave differently. So there's something those organisms are producing which allows them to give a worse clinical outcome that you would otherwise expect for a susceptible antimicrobial. Okay, so we took 600 cases, 600 Pseudomonas isolates from different cases, and we sequenced them, looked at antimicrobial sensitivity, contact lens disinfectant. And just an important point about that is that when people use contact lens disinfectants, it's used against a standard P014 Pseudomonas. But lots of different types of Pseudomonas may be resistant to ordinary contact lens disinfectant solutions, and it's a really important point, and I think it's going to change the industry somewhat in that regard. Anyway, so the next thing is to look at bacterial host factors and then possible treatments for that. So if Pseudomonas, although we think of Pseudomonas aeruginosa as one organism, it actually breaks down into 2 simple groups, and these 2 groups probably represent 2 different types of sub-organisms. There's group 1 and group 2, and I think if you can just remember that, that's quite important. So we looked at all the different types of Pseudomonas organisms, and the isolates which affect the eye tend to be grouped together. So all the Pseudomonas isolates which affect the eye tend to be cousins or brothers or sisters of each other. So there's something interesting about that. They tend to be more motile and affect the eye. And one of the important things is most Pseudomonas aeruginosa have acquired an exotoxin. So usually they either produce exotoxin S or exotoxin U. And when the Pseudomonas infects a cell, basically what it does, it uses this protein over here, which is like a hypodermic needle, and injects the exotoxin S into the cell or exotoxin U. So if exotoxin U goes into the cell, that's a phospholipase. It breaks down the cell membrane, the cell lyses. Exotoxin S, it just tends to interfere with the cytoskeleton, so it's more of an invasive form. So you tend to get more persistent infections with exotoxin X, but more severe infections with exotoxin U. So knowing that, the question is, how can we deal with it? So basically, we took the 600 or 350 patients, I forget now, and then worked out the mean healing time according to ulcer size. So obviously, bigger ulcers take longer to heal. So you have to do a ratio of healing time to ulcer size to kind of standardize that, if that makes sense. And then the point being was that we then said, those patients that did more than 2 standard deviations worse in the meantime we consider a bad outcome. And those patients that healed in 2 standard deviations less than the mean healing time would be regarded as a good outcome. So looking at that, patients which were infected with Pseudomonas that produced exotoxin U had a much worse outcome, or predominated in the bad group than the good group. So we know exotoxin U is a cause for a worse outcome. So knowing that, if you go through evolution, whether you're a Pseudomonas or a bee or a snake, most of these creatures produce a phospholipase, and that's how they produce their toxins to, inhibit or kill the host. So the question is, so we've been developing and looking at different chemicals to inhibit the exotoxin U and the phospholipase, and that shows promise. And just 2 final slides. We also took the whole population of Pseudomonas and tested them against different bacteriophages. So as you know, bacteriophage is a virus which infects the bacteria, and they're very effective at wiping out infections, whether it be in the lung, as this case over here, or in the ocular isolates. So we feel we're coming up with different cocktails of phages which can be used in combination with these treatments to wipe out the organism. And I think this is a really exciting way forwards. And putting everything I've told you into one big slide, I'm just going to show you this. Basically, these are all the isolates divided into group 1 and group 2, and we can tell whether they survive in contact lens solutions, whether they're phage susceptible or resistant, good or poor outcomes, ciprofloxacin sensitivity, and whether they're group 1 or group 2. And I think I'm out of time. Okay.